Okay. My name is Laura Ettinger, and I am here interviewing Dr. Nanette Wenger. And I am delighted to be with you, Dr. Wenger. Dr. Wenger is the 2023 winner of the Alma Dea Morani MD Renaissance Woman Award. This award is given by the Women in Medicine Legacy Foundation every year to an outstanding woman physician or scientist who has left a significant mark on history and pivotally advanced the future. The Women in Medicine Legacy Foundation does an oral history series with our award winners, so it is a terrific honor to be spending time with Dr. Wenger and learning about her journey. Our interview today is taking place on Monday, December 8th, 2025, with Dr. Wenger in her office at Emory University in Atlanta and me at my office at Clarkson University in Potsdam, New York. So again, Dr. Wenger, thank you so much for agreeing to do this interview. I'm really pleased to be with you here today.
I'm delighted to participate, but my office, even though I'm a faculty member at the Emory University School of Medicine, my clinical base of operations, and as a matter of fact, my academic and research base is Grady Memorial Hospital, which is one of the major teaching hospitals of the Emory University School of Medicine.
I stand corrected. Thank you very much. So Dr. Wenger is at the Grady Memorial Hospital. So Dr. Wenger, I was thinking of just asking you to begin at the beginning. And could you tell me a little bit about your early life, your childhood, your family? Why don't we start there?
Well, I grew up in on Long Island and went to public school. As a matter of fact, public school 63 Queens, which was the neighborhood school, and then made a major departure because I went to high school in Manhattan. And this meant riding either the subway or the Long Island Railroad into Manhattan every day. I think you can imagine how much of a challenge it was to persuade my parents that it was safe to allow their older daughter to do all of this traveling alone. And I think it was only the prestige of the Hunter College High School that persuaded them to give me that opportunity. Hunter College High School was started as the training school for teachers of Hunter College, and it is competitive admission from the 5 boroughs of the city of New York. So that I had the opportunity to interact with enormously talented women, all women of various backgrounds, and was very comfortable being in a multi-ethnic, multi-racial, multi-socioeconomic setting that mimicked the real world, except that these were people who competitively made it into that class.
Amazing. How how did you decide that you wanted to go to Hunter College High School?
Well, I expect that it was some of my teachers during my last year or two who said that the neighborhood high school probably would not afford me an adequate challenge, and said I needed to be challenged academically and suggested the Hunter College High School. And I did the competitive admission process and fortunately was accepted. And then it was the competitive persuasion process that was done.
And can you say a little bit about what you were like in high school? How might someone have described you in high school?
Well, I have always been a people person, and I was a member of numerous clubs, the biology club and one of the writing clubs and so forth. So I had a number of after school activities, but I was always interested in science. But when you're interested in science, either you say, I'm going to be a lab person or I'm going to be a people person. And I was the people person. And the ideal marriage of that was medicine. And I think early on, I thought in secondary school, I thought seriously about pre med and medical school. And my parents are not physicians, but one of my father's sisters in Europe was a surgeon. So, as a matter of fact, when people ask my two daughters who are physicians, what is it like to be a woman physician? They say, we're third generation. So, there was a background, and a number of my cousins, older cousins, were in medicine. So I was exposed to that early on.
Okay.
And the curriculum at Hunter College High School was fixed. There really were no electives, but there was a sizable exposure to laboratory and biology and chemistry. And as I was finishing secondary school, the question was, where would I go to college? And my parents made it eminently clear that they would not have their older daughter away for 8 years. So that if I thought that I might be going out of town for medical school, they wanted me in town at least for college. And I decided I would stay in town for college and went right next door to Hunter College. Uh, and and Hunter College had the luxury of a pre-medical major, which was a multidisciplinary major, and that meant that you didn't have to have a minor. So that the course requirements were the biology, chemistry, physics, etc., for medical school, but it still gave me the opportunity to take a number of courses in other disciplines that I would not have been able to do had I had to take a minor. And I loved college. I was involved in every aspect. I was an officer of student government. I went to conferences for student government during the summer. Uh, I was really very involved in college life. I was a member of sorority. I was a member of Phi Sigma Sigma and active in my sorority. And I just loved college. Also, Hunter College has a famous interclass competition called Sing, which is a competition among the 4 years. And one of my closest friends to date was the head of Sing, the artistic director, and I was the business manager of Sing. So, and that cemented our relationship. And I just loved college life. My science professors suggested that I try to apply to medical school after 3 years of college. And they said, you probably need the experience of applying to medical school the first time, so you will do better the second time. That was the first time anybody had ever told me that applying was a challenge. Uh, I sent in my applications, I did my interviews, and uh, was delighted to be able to select my first choice, which was the Harvard Medical School after 3 years of college. So that my fourth year of college was synonymous with my first year of medical school. And I didn't get my college diploma until I had satisfactorily completed my first year at the Harvard Medical School.
Amazing.
So
I,
I miss being a senior. I missed all of the senior fun. But I was at the Harvard Medical School and was thrilled beyond belief.
wow. I have so many things I want to follow up on. That's also interesting. can we actually go back to your parents who allowed you, it sounds like, to take the Long Island Railroad to Hunter College High School and yeah, can you tell me a little bit more about them?
My parents were both born in Russia in a small town outside of what is now Ukraine, outside of Kiev. They were highly educated. They spoke multiple languages and came from very intellectual families. Uh, my mother came to the US on the last boat to leave before the First World War, because her family had gone earlier, but she was finishing up her university studies and came. My father's family was in the lumber business in Russia, and their main client was Japan. So that among the languages that my father spoke was a fluent Japanese. And when he was escaping Russia to avoid conscription into the Tsarist army, he went through Siberia uh, and to Japan and settled in Yokohama and stayed there for several years. And again, speaking a fluent Japanese and having the contacts of his family made that very comfortable for him. And as a child, I had pictures of him sitting dressed in full kimono with his Japanese friends and colleagues, many of whom remained friends as he transitioned to the US.
Oh, what a story. Both of your parents actually. So both of your parents came to New York then, the New York City area.
No, no, my mother came to New York. My father came initially to San Francisco and
Okay.
then was transferred to New York. My father had been friends with my mother's oldest sister, but really never knew my mother growing up, even though they were in the same community. And the older sister was the one who introduced them in New York.
Okay. Okay. And then what did they do in New York?
Well, my my mother had been a very successful artist, had done some magazine covers, and I still have some of the original watercolors of those. But when she married, she stopped her art career and did a great deal of community volunteer work. My father worked with the group that he had become involved with in Yokohama, and that was HIAS, the Hebrew uh, Immigrant and Assistance Group, and was very much involved with helping get immigrants to the US. And his entire career was with United HIAS.
Fantastic. Um, and uh, you grew up with a younger sister, is that correct?
My sister was 5 years younger, and because of that, I did, I think, the pioneering work because she followed me to Hunter High School and to Hunter College, and then went on to get a graduate degree in Yale and was an historian. So historians run in my family.
I like that. Uh, uh, and when you think about your parents, um, I guess what you mentioned that uh, they were very intellectual. I guess what qualities or values stand out most to you when you think back to, I guess, your growing up years and what you were taught by them?
Well, the things that they valued were music and art and literature. So the books abounded at our house. They were the usual piano lessons that you might anticipate. But weekends were very often involved with trips into New York to museums. And museums were just part of my growing up, as was music. Both of my parents loved opera, and as a high school student particularly, and later on in college, it was a luxury to go to the old Metropolitan Opera House in New York before they moved to Lincoln Center. And music was very much a part of my early life. And actually, it's carried over as a hobby across the decades.
Wonderful, wonderful. Um, what other kinds of things were you interested in when you were growing up? I thought I read somewhere that you were an accomplished ballet dancer up until medical school.
Yeah. Well, first place, I was a Girl Scout and did all the things that the Girl Scouts usually do. But I enjoyed ballet. I never wanted to do it seriously. I always did it for fun because I enjoyed the music and I enjoyed the challenge. And being in New York allowed me to be in the junior company of a group. And it was just wonderful exercise, relaxation, camaraderie. And of course, I didn't have the challenge that all of my colleagues did who wanted to do ballet professionally. I never wanted to do it professionally. I was doing it because I thoroughly enjoyed it. And that was a challenge to my instructors who said, "Why are you doing this?" And I said, "Because I like it." And I'm not sure they believed me.
I love that.
Fortunately, I was never good enough to ever consider doing it seriously, but I enjoyed it. And as a matter of fact, as my daughters were growing up, and all of them went to the Atlanta Ballet School for ballet training, when I drove them there, I worked with the Atlanta School of Ballet. And what they did is they had ballet classes, they had ballet exercise classes for the parents while we waited for the children.
That's incredible.
Yeah,
That's
well,
what a great idea.
it was much better than sitting in the car and listening to the radio.
Yeah, that sounds fantastic. I have two daughters, and I don't think I ever had an opportunity like that. That sounds very smart. Um, Smart way to get the parents involved. Um, what about you had mentioned that you had always been interested in science and that you're a people person, and so your interest was in medicine. Um, do you remember like what got you interested in science? Or was it just something you were always into?
Well, I think it really was the thrill of discovery. And in the laboratory, everything that you do is discovery, beginning with the dissections in anatomy and the problems in chemistry. It's trying to solve problems and being able to get answers.
That's good. Uh, Going back for a moment to Hunter College High School, uh, which sounded like a great environment. Um, did you have peers who eventually were applying to medical school from high school?
I had one or two of the women in my class and the class behind me who were interested in medicine. And one of them subsequently went to Yale, and I'm not sure where the other one went. But there were a few of us who were interested in medicine, and our teachers absolutely supported and encouraged that interest. And and no one really told us that it was a problem. So that along the way, this was not essentially presented to us as being something that was impossible to accomplish. The idea was you apply and you're accepted. And I think that that approach very much influenced my interviews. I went to the interviews, enjoying the interview process and everything else, but not being challenged. Only later did I realize that there were quotas at all the schools. Virtually all of the schools had quotas on women. There was a Jewish quota in virtually all of the medical schools. But I was blissfully unaware of that until a number of years later. And so were many of the other women. I think the men were told about this as they were applying. They were told about quotas and told about where to apply, etc. The men received much more counseling because the counselors had much more experience with men going to medical school. The counselors did not have that much experience with women in medicine. And they knew that we were determined. They encouraged us. But I think probably fortunately, they didn't tell us that this was not an easy path.
Interesting. And here, I just want to make sure, um, I think I know what you're talking about here. This is all talking about applying to medical school, right?
Yes,
That
yes.
it was, and you're talking about quotas for women, for Jews. I know there were also quotas for Black people at medical schools. Um,
Well, there was virtually no enrollment of Blacks in the premier medical schools. So there really wasn't a quota. There was a woman in the class, a Black woman in the class ahead of me at Harvard, who ended up with a very successful surgical career. But there really was no official quota on any racial or ethnic minority because they weren't considered part of the applicant pool.
okay,
And
okay.
as we look at it today, it's a tragedy that all of us accepted this because that is the way it was.
And just to clarify, is it correct that you started at Harvard Medical School in 1950?
Yes, and I
Okay,
graduated in 54.
54. And so your first year at Harvard Medical School in 1950 to 51 was also considered kind of your last year of college,
That's
right?
right.
And then you got your diploma from Hunter College in 1951, but having
Yes,
completed that year at Harvard
yes.
Medical School. Okay. So
And,
you were,
and, and along the way, I remained very much involved with the Alumni Association of Hunter College High School. And actually, within the last couple of years, I've hosted a reception at my home for people who were in the Southeast from Hunter. And uh, I've been involved with the group, which is very impressive. And Hunter College High School, now co ed, is totally different from when I went there. And as a matter of fact, I think it was 2 years ago, I was invited to give the commencement address at Hunter College High School and was completely honored to be able to do that. It was in the auditorium of Hunter College, where I had been involved with Sing. And I was amazed by how relatively small the auditorium seemed to me in the 2020s compared with the huge auditorium I perceived as an undergraduate there.
amazing. That's amazing. I'm sure that the students at Hunter College High School were very honored that you accepted that and that you were going to give the commencement address. That's fantastic. So Harvard Medical School, let's talk more about that. So, you said that you you didn't know about the quotas at that time when you entered in 1950. It sounds like you didn't even expect that it would be difficult to get into medical school, right? Because you had been told maybe you should apply a year early in case you need to practice, essentially. But then you clearly got into exactly where you wanted to go. Um, why did you choose Harvard Medical School?
I'm not really sure, except that I was very impressed with the interview process. And I didn't realize that you weren't supposed to ask your interviewer questions. And I did. Uh, in all of my interviews, I asked my interviewers questions. And I really appreciated the answers that I got from my interviewers at Harvard and felt that that was the place that I wanted to go. And when I started, I was fairly confident because I had gotten accepted after 3 years of college to a large number of the schools to which I applied.
Okay. And so how many women were, did you enter with?
That by decision of the Board of Overseers, there were 10 women in each class. And Harvard was relatively late among the medical schools in admitting women. And the decision of the Board of Overseers was that there would be the experience of 10 years with women at Harvard. And that 10 years expired the year that my class graduated. And based on that 10-year experience, the decision would be made whether or not to incorporate women in the university charter. So we were essentially there on probation. And as such, we were not entitled to university housing. The men lived in the university dormitory in Vanderbilt Hall under house rules at the time, and the women lived in apartments in town.
And what was that like, that the men were all living in, one place and you were living, the 10 of you were living separately?
Well, one of my roommate was a medical student who was a year ahead. There was another woman medical student in the apartment complex. So we did a lot of our meal functions together. We breakfast is always an on the run. Lunch we had at Vanderbilt Hall. We walked across the street during our preclinical years. And the women did a lot of dinners together. But the attitude of the men in my class was wonderful. They took care of the women and made it rather challenging for any of the faculty members who were trying to dismiss the women. So they were our allies. My lab partners have remained close friends over the decades. And I had a wonderful time in medical school. I enjoyed to some extent the preclinical years, but I couldn't wait to start seeing patients. And my clinical experience with some of the greats of medicine and cardiology was wonderful. And I loved the patient contact, even though many of them were a little bit hesitant, not only by a medical student, but by a woman medical student. But I had no problem convincing them that I belonged there. And again, I think women enjoy listening. That's probably a female trait. And many patients commented to me over the years that you've listened to me more than any of the other doctors. Because taking a clinical history, the question is, are you going to interrupt to get your answers, or are you going to listen and give the patient control? And I think my accomplishments were related to the fact that I gave patients control.
That's fascinating. Uh, and just to follow up about that, you said that patients sometimes, when you were in your clinical years in medical school and working with patients, they were hesitant perhaps for two reasons. One, you were a medical student, right? You didn't have the MD yet, but also that you were a woman. And you're saying that when you showed that you listened and gave them control, that um, sounds like they did more than accept you. But what about initially? Like, how did you deal with their hesitancy initially? Do you remember sort of what did you do to convince them that it was going to be okay dealing with a medical student and a medical student who was also female?
Well, I think a lot of it was that I was fairly confident that I knew that what I was doing. And I would introduce myself saying that I'm Nanette K. I am a third year or then subsequently fourth year medical student at the Harvard Medical School, and I'm working with your doctor so and so to take care of you.
Okay.
And that positioned me where I wanted to be.
Okay. And speaking of that confidence, was that something that you always had? We know that that's sometimes something that women struggle with, right? That girls and women can, I mean, people can struggle with that too, of course. But do you think that was something you always had?
I think so because I knew I was where I wanted to be. I knew that my training and education was superior and that this was what I was able to accomplish if I continued in that pathway. So I was very comfortable with me as a medical student.
You mentioned that your peers were wonderful, your male, majority
Oh
male
yeah.
peers.
Oh yes.
Yeah. And you said that, um, I guess I thought you were saying that if faculty were expressing some hesitancy about women, your male peers kind of jumped in about that. Could you talk more about that a little bit?
I think that there were one or two faculty members who either were uncomfortable with women or really didn't think we belonged there. And their attitude was not like the rest of the faculty. And by various games and what have you, the men made it clear to them that that was not acceptable. And there was one professor who shall remain unnamed who really went after the women, and the men came up with a wonderful solution. He suggested that we all buy fairly short skirts and sit in the front row of the lecture hall and cross our legs. And we did that at this professor's lecture. No one said a word, but he got the message and he backed off. It was something I think the women would have never thought about, but the men said, let's do this.
Wow, incredible. Um, you also mentioned that you had some of the greats, that you were being taught by some of the greats in cardiology. And I think, or maybe you were talking about your clinical years in medical school. When did you first become interested in cardiology?
Oh, I think cardiology interested me early on because this was almost the frontier of medicine. We were beginning to translate the laboratory to the bedside. It was the beginning of precise diagnosis. It was the beginning of new medications. Uh, and it it was an area where there was literally discovery month by month. And then, of course, I was exposed to some of the greats as my instructors. When I was at the Beth Israel Hospital, Dr. Herman Blumgart, who was physician in chief, was one of my attendings on ward rounds and taught me a huge amount about patients and disease and patient care. And then one of my other attendings was Dr. Louis Wolf of the Wolf Parkinson White syndrome. Uh, I was exposed to teaching from Dr. Paul Dudley White. And then some of the surgeons who were just beginning cardiac surgery were among the lecturers. And the fact that you could operate on the heart, operate on a human heart, was just amazing. And then, of course, at the Boston Children's Hospital, there was exposure to Dr. Alexander Nadis, who was essentially one of the founders of pediatric cardiology. And we were beginning to make a diagnosis, a specific diagnosis, rather than just saying congenital heart disease, because that was enough. You couldn't do anything for it. But once there became an approach for specific congenital heart diseases, the surgeons taught us that we had to learn how to make a diagnosis to say who was eligible for this life saving surgery. So it was just a wonderful period of discovery.
Wonderful. Um, can you say a little more about, if I got the names right, Dr. Bloomberg, Dr. Wolf, Dr. White, the kinds of things um, you learned from them about patient care, or whatever it was that really sticks with you about what you learned from them?
Well, one of the statements that you hear again and again in the Harvard Medical School is that the secret of taking care of patients is to care for the patient. And we heard that beginning in our first clinical lecture, and we heard that again and again, which meant that there was a lot of interest in the patient's disease. But the main interest in the research lab as well had to be focused on the care of the patient. And that has remained with me throughout my career.
Thank you. Uh, how did you decide where you were going to do your internship and residency um, as you were graduating from Harvard Medical School in 1954?
Well, that was a relatively difficult decision to make because there was, of course, the interest of my family in my coming back to New York. But I was offered a position, an internship at the Beth Israel Hospital in New York, in Boston, sorry, and was offered the position as the first woman house officer to be there. But I had, during my senior year, become an acting intern because of the illness of one of the interns and had the best 3 months of an internship already under my belt as a senior medical student. Those were the days of mixed internships. So it was not all internal medicine. There was OB and surgery and what have you. So I'd had the best 3 months of the wards. And I decided that I was going to go to the Mount Sinai Hospital in New York. Again, this was the Mount Sinai Hospital where there was no medical school, so that all of the teaching went to the house staff. And it was, as people have joked, the days that the giants walked the walls of those hospitals, because my attending professor in pediatrics was Dr. Bella Schick of the Schick test. My attending physician in OBGYN was Alan Guttmacher of OB fame. Alexander Gutman, who was chief of medicine, was the editor of the Green Journal. Simon Dack was in cardiology. Arthur Master had just stepped down as chief of cardiology. That's Arthur Master of the Master two-step test. And Dr. Charles Friedberg had just taken over as chief of cardiology. So here were just some of the giants that I was exposed to. And as a matter of fact, during my rotation on medicine, I had as one of my attendings Dr. Beryl Crone of Crohn's disease. And when subsequently, when I was a junior attending here at Emory and knew a fair bit about Crohn's disease, my students, my residents, and actually my co-faculty members said, "When did you learn all this about Crohn's disease?" I said, "From Beryl Crone."
Amazing. And uh, I think I know the answer, but I just want to confirm that while you were at Mount Sinai, you were aware that you were being surrounded by the giants, that you were being taught by the giants, or was that more later that you realized,
Oh
wow,
no, oh no, because all I had to do was go to the literature and see that the literature that I was reviewing was by the people I was making rounds with. And that is such a luxury. And the library at the Mount Sinai Hospital was just one of the gorgeous places. The old fashioned wood paneled library with the leather bound volumes of the journals, etc. And everything we needed was at our fingertips to review and to look at, etc. So, and we were encouraged as we saw patients before we presented at at the Mount Sinai Hospital. The message was that the diagnosis had to be made the night of admission. We stayed up all night. We did all the lab work by ourselves. There were no night lab technicians. We were the lab technicians. And after that, we had to run to the library and see what we could get so that we could present to our attending in the morning. Uh, but it taught me the automatic reflex of going to the literature, either for a differential diagnosis of the patient's symptoms or for a confirmation of or what I had to do additionally if I thought I knew the diagnosis, etc. So that just became habit.
Fantastic. Um, so, so just to remember the years, right? You were an intern at Mount Sinai from 1954 to 55, then a resident there from 55 to 56, and then chief resident 1956 to 1957. And I understand, or I think I read that you were the first woman chief resident at Mount Sinai
No,
Hospital.
I was not chief resident. Because instead what I did is that I did a year of cardiology.
Okay,
Yeah, I did
okay,
a year of because Dr. Friedberg had just taken over as chief of cardiology, and he invited me to be his first cardiology. They were called residents then, but it was fellow,
okay.
and it was just so exciting because I spent my days with the people whose work I was reading about. And of course, Dr. Friedberg is probably the author of the last sole author textbook of cardiology, and that was the standard of care. And he was considered probably the eminent cardiologist in New York City. So seeing his patients was like seeing the famous from really worldwide who came to see him. And he had a major influence on me because, as you might expect, his rich and famous patients were not thrilled to see a medical fellow and a woman medical fellow. And what Dr. Friedberg did has taught me how to work with juniors over the years. He said to his patients, "This is the doctor who will guide the care of your children and your grandchildren." That was the way he introduced me to his patients. At first place, it was a huge challenge. What am I going to do to live up to this introduction? But it made the patients accept me. And I can see him saying those words to this day. And he was the eminent clinician, and just making rounds with him was like reading a textbook, his textbook.
So tell me more about what else you learned from him in addition to how to introduce junior colleagues, which what a brilliant approach he took. Um, what else did you learn from him?
I just learned from him how to deal with patients with a difficult diagnosis or a challenging test schedule. And, in medical school, we were taught you never sit on the patient's bed. You always stand or sit in a chair. And I knew something was bad when he would sit on the patient's bed. And he would often sit on their bed and hold their hands and say, "Let's talk." And I learned how he presented bad news to patients and how he gave them hope for what was the solution or the temporizing for what their problem was, or how he tried to persuade them to have a test like cardiac catheterization, which was relatively new at that time, or to go for the very new cardiac surgery that was beginning for valve disease. And he would really take his time and explain, and particularly explain why he was recommending what he was recommending. And he always told the patients that they were still in charge, but that he was giving them the information that would allow them to be informedly in charge. And it's something I still do every day. It's something I teach every day. But again, making rounds with him day in and day out was such a learning experience of how to do really quality patient care. And his care was identical if it was one of the ward patients on the charity service, or if it was one of the rich and famous that you would recognize by name. It was the identical approach. And that conveyed a message as well.
Thank you. That's wonderful. Can you say more about being a woman uh, in as an intern and resident, and then in what was essentially your fellowship in cardiology at Mount Sinai? Um, were there other women interns and residents there?
They were just a handful, but during my tenure there, one of the women was chief resident, and she was a brilliant woman. And I think because there were so few of us, the term lady doctor would identify you on a particular service, but it was a descriptor rather than a put down. And fortunately, every one of the women with whom I worked were really good and were really dedicated. But I was the first woman in the cardiology service with a group of men, and I was the chief. And it was not a problem because we all cooperated. And we were all so excited about what we were learning that there really wasn't any opportunity to compete. We all wanted to do different things early on.
Is there anything else you'd like to say about your time at Mount Sinai?
Well, part of the training in cardiology was doing the master's two-step test, which was the first beginning of an exercise test and got me very much involved in the exercise physiology that I had been interested in medical school. And I've probably done more master two-step tests than anyone currently alive. And as I began to learn more about exercise physiology, realized its limitations. But the fact that exercise was a modality for cardiac evaluation was comfortable in my mind and influenced a lot of things I did later. And every day during my fellowship, at the end of the day, I read electrocardiograms with Dr. Simon Dack, who was probably the great electrocardiographer of all times, and just learned how to read and why, and the importance of precision, etc. And remember that at that time, there were relatively few tests in cardiology. We had the chest x-ray, we had the electrocardiogram. Cardiac catheterization was just beginning. Diagnostic catheterizations were very rare. There was no echocardiography. The only exercise modality was the master two-step test. So the electrocardiogram became a critical part of what we did.
Can you go back for a moment? The master two-step test. Can you describe that?
Yes, these were patients who were suspected of having coronary disease, and the idea was to exercise them and to see if their electrocardiogram became abnormal. And they walked up and down 2 steps for a number of repetitions, and then were brought to a bed where they would lie down and the electrocardiogram would be taken again to see if there was any abnormality. But as we've learned from subsequent, more sophisticated exercise testing, that was too late to see any of the changes that might have been a problem. But it taught me the safety of doing it. And of course, it was done on very stable patients.
Okay. Anything else you want to say about your time at Mount Sinai before we move on to your move to Atlanta?
Well, again, the surgeons there were beginning to do very exciting valve surgery, and therefore we learned how to catheterize the heart. And remember, at that time we were doing only venous catheterizations, no arterial catheterizations, and how to use the limited data that we had uh, to prepare the diagnosis. The majority of procedures that were done early on were mitral valve surgery. And I had seen some of the mitral valve surgery as a medical student at the Brigham. And here, seeing it again, uh, we were just beginning to enroll patients in they weren't clinical trials because they weren't randomized, but at least there were registries. And the idea is we have to see what is the science beyond what we're doing. We were essentially building the airplane while we were flying it. And I learned the importance of evaluating what you're doing. Just because it's new and exciting doesn't mean it's good. So the whole concept of evaluation was very, very important.
And may I ask, like, what did it feel like to be building the airplane while you were flying it? Because as an outsider to it, it sounds potentially terrified to be in that position, but that may not have been how it felt at all.
Well, not at all, because what we saw is that diseases that were ultimately morbid or fatal were being cured,
Mm.
and or at least ameliorated. And the guidelines that came out over the years really taught us about the timing of it, the suitability of it, the details, the refinement of it. And that has been the case with every new procedure that has come along.
So it sounds like it was just very exciting, right?
Absolutely,
Yeah.
absolutely.
Okay.
And as a matter of fact, that excitement continues today, because now probably the major advances are being made in the world of imaging. And we're able to do non-invasively what previously required invasive studies. And being able to do something non-invasively gives you the opportunity to do follow-up testing to see whether you're progressing, whether you're not, whether you're improving, whether you're not. And I think the next frontier is going to be an imaging frontier.
Excellent. Uh, let's go to Atlanta then. You're already in Atlanta. But you came to Grady and Emory early in your career. I see from your CV that you became senior assistant resident in medicine at Grady Memorial Hospital starting in 1958. And then you went on to become a fellow in cardiology there, 1958 to 1959. So can you talk about what it was like to make the move from New York City to Atlanta and how you decided to do that?
Well, the fascinating study is the study in chance. And my husband and I had dated when I was in medical school, but neither of us were ready for marriage. And he began to date others, I began to date others, and that was it. And while I was at Mount Sinai, he had been approached to come to Grady as chief of gastroenterology and stopped at Mount Sinai to talk to one of the people who had been his colleague, if you will, to say, what do you do as chief? Heard my name on the overhead page, and the rest was history. So my husband went to Emory a year before I did, and we married, and I followed him to Emory.
Uh, Trying to decide if I want to ask you more about meeting your husband now or later. Um, Maybe I'll ask you now. Can you tell me? So you said you began dating in medical school. How did, so was he also at Harvard Medical School?
No, he was in the military at the time,
Okay.
and he was in the public health service. But it wasn't really an arranged marriage, but our fathers were friends, and our fathers introduced us.
Okay.
But
Okay.
it took a while for things to happen.
Okay. Okay. And what year did you get married?
I got married just before I came to Atlanta. I came
Okay.
to Atlanta as a bride, which
Okay.
is which is one of the reasons for my decision as to what to do. When I came to Atlanta, there was the beginning of an increased time, both in internal medicine and in cardiology. And I had had 2.5 years of internal medicine training. And I said, let me just, as I was getting accustomed to being a wife, a Southerner, a physician in segregated society. I did 6 months of senior residency so that I had a full 3 months, 3 years of internal medicine. And then cardiology training was just beginning to be 2 years. And I said, this is a wonderful opportunity for me to get additional training. I was pregnant at the time. And again, to do multiple things. So I had a year and a half of training within the Emory University system. And that was extremely useful. And then joined the faculty, which was just a natural progression.
Okay.
You see,
Okay.
you have to know something about the Southern medical schools to understand what was going on at Emory. And this was a result of the Flexner report that was looking at medical education. And I had grown up in the North where there were full time faculty both in clinical medicine and in basic science. In the Southern schools, there were only full time faculty in the basic science. And for the clinical faculty, the teaching was done by volunteers from the community. And
Wow.
when Willis Hurst became chair of medicine at Emory, he wanted to develop a full time faculty in clinical medicine, which had never existed in the Southern schools. But just think for a moment who would come to a segregated public hospital in the Deep South? And what Willis did was very wise. He went to the prestigious training programs and got the people who were just finishing their training to come as faculty. So my husband, who was at the University of Chicago, one of the most prestigious gastroenterology training programs, went from being a fellow in gastroenterology to being chief of gastroenterology at the Atlanta VA hospital and assistant chief of medicine. There were no underlings, they were just the chiefs. I went from being a fellow in cardiology at the Mount Sinai Hospital and a little bit of training at Emory to being chief of the cardiac clinics at Grady Memorial Hospital. And all of our colleagues were the same, coming out of prestigious institutions. We were a wonderful, cohesive group. We felt that we were changing the world because we would fix everything that we hadn't liked about our training program and put it in and make it new and better. If it worked, we kept it. If it didn't work, we changed it. And there was no one to tell us that it couldn't be done because it had never been done before. And it was probably some of the most exciting years that I spent because I was able to implement so many of the ideas that had been wandering around in my brain for a long, long time. And as chief of the clinics at Grady, I was able to start an anticoagulant clinic. We called it the Coumadin Clinic because Coumadin was the only anticoagulant. But at that time, it took 2 days to get the report. And when the laboratory called back to the doctors, they didn't even remember the patient and they didn't know how to prescribe. And it was not a good setting. And I set up a system before any of the Standing Stone or current systems where we had one dose of anticoagulants. The patients were given one pill or half a pill, and depending on what that time prothrombin times were what was being done, not INR, the nurses would prescribe the Coumadin, and they didn't have to call the physicians. They had the patients. We developed a teaching program for patients where they had to pass an examination in a little paper book before they were started on anticoagulant therapy. And the nurses ran the anticoagulant clinic. There was a period of time when this was the largest Coumadin clinic in the country, and compared with other major medical centers, it was run by nurses who did not even have a baccalaureate. They were diploma school nurses who were the nurses that we employed. And our outcomes were as good as the major prestigious centers. And the nurses loved the responsibility. And we expanded that. There was so much rheumatic fever then at the time. And patients had to get rheumatic fever prophylaxis, which was either pills every day or an injection of penicillin every month. And the nurses ran the prevention clinic out of a card box in the office where they would call the patients and remind them to come in. And I think I inadvertently started the first patient education program in the country because when I came to Grady, the assumption by the people in power was that if you were indigent, you were not educated, you were not informed. And therefore, when patients went to the pharmacy, they got their medication by number. You got a number 5, a number 7, a number 9. And first of all, I was annoyed at having to learn all the numbers and learn what they were. But my approach to patients told me that this was not appropriate. And one of my first tasks as chief of the clinic was to write to the pharmacy committee to say, this is not appropriate. You need to give the patients their drugs by name and tell them what it's for. And my secretary reminded me years later that I would repeat that same letter and just change the date, the first of every month. It took almost 2 years, but we finally got medications by name. But what we did is to using the old mimeograph machine to make little paper handouts for patients that said, number 1 is digitalis. This is your heart medicine. Number 5 is Coumadin. This is your blood thinner. And we began to realize that having informed patients allowed us to give better care. And we developed handouts. We developed handouts for diet, for everything that we recommended for patients. And we had a whole group of patient handouts that were part of our care. And if you remember, the weed system of the organized medical record is diagnosis, therapy, and education. And this was part of the education that was prescribed at each clinic visit so that the patients got this education.
So there's so much here I want to ask about. This is also interesting. Why so much resistance at the pharmacy from changing from numbers to names? Was it that the people there thought it was a waste of time?
No, they thought the patients would not understand it, would not remember it, and that it wasn't important.
Okay. Okay. And
And
how,
it had been done, it had always been done that way. And here was this funny talking lady doctor who wanted to change it.
so how did you convince them?
After a while, what we did is we took out the original letters and crossed out the dates and sent it to them with how long I had been asking for it.
Persistence, I hear, is quite a theme in your life.
Well, again, if I think it's important, and I thought this was important, then I am very, very persistent. And I hang on like a bulldog. And there's no point in getting angry, but there's just point in informing, informing, and informing. And that was what I did. And eventually someone listened.
And you said that all of you who came to be full-time clinical faculty members, it sounds like you were all young and from these prestigious programs, right? You founded the cardiac clinics, you were the founding director of the cardiac clinics when you were right about 29 or 30 years old, something like that. This was in 1960, right? Um, what was it like to be with this group of relatively, young people from these prestigious programs? You know, it was kind of flat, right? In a sense, there weren't older people that you were having to deal with for the most part. What was that like?
Well, it was lovely. As I said, no one told us that we couldn't do it because it had never been done before. And Dr. Hurst's emphasis was excellence. And as long as there was quality, and as long as there was measurement, as long as there was accountability, we did that. And I did things that would have never been possible had I remained in New York or Boston, because I started the first early ambulation after myocardial infarction program in the world and on the Grady wards. I had learned a little bit about ambulation, or really the chair treatment for myocardial infarction from Dr. Sam Levine at the Brigham, who put patients in a chair. At that time, patients were kept at bed rest for several months and hospitalized for ages and invalided for years. And the basis for that was the pathology studies that patients who died took months and months for their myocardium to heal. Well, I had had about 4 months of pathology training when I was at the Mount Sinai Hospital. And I realized that there was a difference between the patients who died and the patients who lived. And we were doing the wrong extrapolation. And we had just begun the coronary care unit. The patients were hardwired to a monitor so that we could see the safety of moving them around and seeing that they didn't develop bad rhythm disturbances. And I had the first federal grant to the hospital from what is now the Department of Health and Human Services. And it was a study of early ambulation and myocardial infarction. And we developed a 21-step program so that for each of the 21 days, the patients did a little bit more. They dangled one day, they walked around the bed the next. And we sent the patients home at 21 days, where everyone was keeping them hospitalized for 4 to 6 months. And we kept good records. We fortunately had no problems. And when I presented the data some 2 years later at the American Heart Association meeting, most of my senior colleagues who were in the front row didn't question the science, but wanted to know how much malpractice insurance I was carrying.
Wow.
And then we started an outpatient rehabilitation program because cardiac rehabilitation pretty much started in Europe, and it was residential rehabilitation where patients went for months to a chalet in the Black Forest or a comparable region and were gradually ambulated and then returned home. And that was just not feasible or functional for the US. And we thought to start an ambulatory exercise program, which we did at Grady Hospital. It was one of the earliest programs in the country and continued for a number of decades. And a number of research papers came out of it, and we gradually changed our inpatient program that went from 21 days to 18 to 13, but it was known as the Emory-Grady protocol and appears in most of the standard textbooks.
Wonderful. A little while ago, you mentioned that when you were coming to Grady, you mentioned an awful lot of life transitions that you were dealing with. You were a new wife, you were, new MD, relatively speaking. You are now becoming a Southerner after living your life in mostly, it sounds like, in the New York City area, with also Boston thrown in there. And you were moving, as you pointed out, to a segregated society in the late 1950s. And eventually, you mentioned you were also pregnant with your first of three daughters. Can you talk a little bit about coming to Atlanta and all these transitions?
It was very much a new life. And I had my family, I had my work, and I had my community. My mother has always been involved with community, and I thought it was important to do the same when I came to Atlanta. And my husband and I were both music lovers, and early on we became involved with the Atlanta Symphony Orchestra when it was still in its primitive, I guess it was, you'd call it a civic center at the Atlanta Civic Center. I've been involved with the symphony now for 6 decades. I joined a synagogue, which was something that I was taught that you always did, and became involved, my husband much more so, in terms of committees and so forth. I joined a number of community groups. We were charter members of the Art Museum after the tragic crash at Orly when we were trying to rebuild the Art Museum. And I joined a women's organization, Hadassah, and ended up being president of two different groups over time. So one of the things that I was taught by my family and that has carried over into everything is that as someone who is educated, employed, etc., you're privileged. And as someone who is privileged, you have the responsibility to give back to the community. And that really determined the things that I did in the community and that I continue to do to date. And I ended up being president of several of the organizations in Atlanta, and had the privilege of being the first woman president of many of them. at a time when the men would say to me, do you know how to run a meeting? And I had a standard response, which people have teased me about since. And I always would say to them, please share with me why you said that. And some of that community effort translated, I was one of the founders of the Atlanta Women's Network, which was a group of women who were working. Because in the South, you didn't work unless you had to work. And those of us who had professions and careers, et cetera, were very much in the minority. And we thought that we needed a support group. And that group has continued to date. And it's also translated into things that I did in the professional societies. I was first woman president of the Georgia Heart Association. And again, the question was, one of my surgical colleagues was the one who nominated me. And some of the older physicians said, are you sure you know how to run an organization? And I gave them my standard response. I was the first woman president of the Georgia chapter of the American College of Cardiology. And as I told them at their meeting last month, it took them 40 years to choose another woman president. And today we currently have a woman president. So, but I've had the privilege of being in leadership positions. And obviously going up to that, you work in committees, you work in et cetera, to get to a leadership position. And I think that's a very, very important part of academic life, to be involved in the professional organizations.
It sounds like you really immersed yourself both in the professional organizations in Atlanta and in Georgia, and also in the community organizations, right? In various ways, you really did both.
And actually, that they helped each other, because for a long time I was on the board of the Jewish Community Center, the Atlanta Jewish Community Center, and we started a cardiac rehabilitation program in the community. And of course, my experience in writing grants helped them get the funding that allowed that to happen. And that's a program that continues to date. We began a program for older adults. And again, I had the experience of writing grants that helped my community effort, because I'd done the grants for my research studies, and grant writing was not a problem for me.
Love it that they fed each other. That's fantastic. Um, what about going, and can you say more about coming from the Northeast to the Southeast, coming from Atlanta, and what that transition was like, what that looked like for you, how that felt?
It was not good. And I had never grown up in a segregated society. And here it was institutionalized and legalized. And I think if we had been in the community rather than in academia, we probably would not have stayed. But within academia, there were a sizable number of like-minded people who worked to preserve public education. You know, there was a movement to close the public schools rather than integrate them. And we were involved with that. And it was my privilege to meet a number of people that were involved in the civil rights, because I got into trouble at Grady within my first year of being in charge of the clinic. And others have told the story, because the hospital was built like an H. The two front areas were white, the two back areas were black. In the clinic, one side was white and one side was black. And the patients were being called to their appointments over a PA system. The white patients were called Mr. or Mrs., the Black patients were called by their first name. And I said, this is not going to happen in my clinic. And I just instructed the people that everyone was to be called Mr. or Mrs. And as you might anticipate, I was in the director's office the next week. And the director was one of the good old boys, but I think one who saw the handwriting on the wall. And I remember our initial conversation. And he said to me, Dr. Wenger, do you know what you've done? And I said, yes, sir. And, I was used to being Dr. Cass, and he was this Dr. Wenger who was getting herself into all kinds of trouble. And he said, do you know that it's against the hospital regulations? And I said, yes, sir. He says, do you know it's probably illegal? And I said, yes, sir. And he said, are you going to do it again? And I said, yes, sir. And he said, well, you're going to be down here and we're going to visit a great deal. This happened for a number of weeks, and we both got tired and wasted our time. And he said, I think I know how to solve this problem. At the time, there was one cafeteria for all the white staff and employees. And you stood in cafeteria line to get your lunch. And we went to the cafeteria together, and we stood in line. And he put his arm around my shoulder and essentially hugged me. Today, he could have lost his job for that. But the message was clear that we were friends and that people were not going to get anywhere by reporting me. The reporting just stopped. We waited them out. But because of that, I had the opportunity to meet both Coretta and Martin King, and was very, very much involved with my congressman, who was John Lewis. And John Lewis taught me a huge amount about good trouble. And I think that if I had not lived in the South, I would not have realized what a peaceful revolution integration was. And I think that it has taught me that some things can be done peacefully, that are major societal changes. And this is why I have great hope that we can make societal changes peacefully rather than otherwise.
I like hearing that from someone with your experience. So John Lewis's Good Trouble that you were engaging in, did you, I guess when you came to the South, when you came to Atlanta, did you expect that's what you were going to be doing, engaging in good trouble?
I had no idea because I had never lived in a segregated society. And it taught me a great deal about how important personal values are. And that if you have personal values that really are part of your core being, that, what is it somebody said? Somebody said that evil is not the opposite of good, indifference is. And that essentially told me that I could not be unresponsive to this.
What about how how you were perceived as a woman and a woman doctor in this community, coming into the Atlanta medical community, a New York doctor, a New York Jewish woman doctor. How, all that intersectionality there. How are you perceived?
Well, I think I was viewed as having cut my teeth on the civil rights issue. And after that, being a woman became less significant. And it was sort of fun because my husband and I would walk into the hospital, and most of our trainees at that time were from the South. We hadn't begun to become as global as we are today. and they would say, "Good morning, Dr. Wenger, ma'am, Dr. Wenger, sir." And that was the way we were greeted. But originally they didn't have any idea of how to treat me because I was a faculty wife, in addition to being a woman physician. But I think that I was good at patient care. I earned my spurs, and uh, there was just never any challenge. And I gradually found people coming to me for advice, coming to me to join, to participate, etc. I must have been on 200 university committees over time and ended up chairing a number of them. Uh, I ended up, I think, contributing to the university as well, because when I was elected to faculty council, I was selected to chair the faculty life course committee. And I was able to introduce into the faculty handbook the concept of maternity leave, which had never existed at the university. And once it became possible for faculty, then it gradually trickled down to trainees and other staff. I was very involved in the establishment of what has become an institution at Emory, and that is the Emeritus College, uh, which is the group of emeritus physicians who meet together and uh, it, who contribute a great deal on a voluntary basis to university life. So that I think there are just a number of things where I think I've made my mark on the university by some of the things that my committees have done. And then, when somebody said, "Can you run an organization?" Well, I've run committees, I've run this, and to get this through the faculty council and university senate, board of trustees, etc., uh, took some doing, but it happened. That's really the important thing. It took a while, it took a lot of persistence, a lot of one-on-one discussion of why is this necessary? We've never had this before. And I think that some of what I've done was recognized because during my latter years on the faculty council, the board of trustees of the university, not just the medical of the university, asked to have some members of the faculty council involved as non-voting members of the board of trustees. And I was one of the people selected to work with a committee of the board of trustees. And I was assigned to the Buildings and Grounds Committee and laughed at it, but it turned out that it was absolutely critical because this was the time that we were building the new Emory University Hospital. And it was the decision of where it was to be built and how it was to be built and the traffic approaches, et cetera. And of course, I was able to provide the patient approaches of what patients would need in a new hospital and their access to ambulatory and inpatient services. So it ended up that I was a very important part of that committee, although buildings and grounds was certainly not my area of expertise.
Fair enough. Uh, Can we just go back for a moment? This faculty life course committee where you said you established maternity leave um, initially for faculty and then it sounds like for staff at Emory. What year was this
I'd
approximately?
have to look it up, but I think it was in the late 1970s.
Wow. Okay. Um, Fantastic. I um, I guess speaking of that, you have three daughters,
Yes,
right? And so when were they born they were born early at in your time at Grady, right?
yes. And there are five years among my three daughters. So uh, I had them all when I was very junior faculty. And uh, I was very fortunate to have very healthy pregnancies. And of course, physicians didn't know anything about working women. And my OBGYN made the arbitrary decision that I could continue to work as long as I didn't gain more than 20 pounds. Now, of course, that would not be any of the recommendations, but I worked until the week before I delivered. And of course, there was no maternity leave. So what I had done is I had saved up vacation a week, my vacation time from the previous year, and I took 1 week of vacation time full time, and then my second week of vacation time half time. But you have to remember that I was 15, 20 minutes from my home to the hospital so that I could go home to pump because there was no portable pumping. And uh, I had the luxury of having full-time nanny for all my children and full-time household help. So things happened.
Yeah. Wow. And how, and by the way, just putting this on the record here, you were talking about pumping breast milk, that you were going back and forth to be able to do that. Um, how, I guess, how were you treated as a young, again, woman physician, married to a fellow physician with young children? How, I mean, did that have any effect on how you were treated either by um, your colleagues or by patients if they knew?
Most of the patients really either were unaware or didn't care.
Hmm.
Uh, they were interested in their medical care
Hmm.
and in what I could do to take care of them. But uh, I was willing to cover for people when they wanted to play golf on the weekend so that they would cover for me when I had to be the room mother at nursery school or what have you. And it was simply about negotiating. And I learned that it was not a shame, but it was very appropriate for me to want to be involved with my children's life, particularly at nursery school, uh, and just to say, I have to do this. What can I do for you in return? And then, and it always worked out. I never got on the golf course. I never got to play tennis, but I got to be room mother and what have you.
And what about you and your husband? What did you end up having to work out, I guess, once these um two important careers, right? As you're having children, you said that you had full-time, household nanny and household help, which I'm sure made a huge difference. But I guess were there things that the two of you had to work out as you were figuring all this out?
Oh, we had to work out our call schedules, and we always had call schedules so that both of us were never on call the same night, so that if we were called in, there was always someone at home. That was pretty easy because, again, he was in charge at VA, and the call schedules weren't that ardent because at that time there wasn't that much that could be done or needed to be done that night that couldn't be done the next morning.
Okay.
Medical care was very different and not that much occurred at night. I'm not sure this applies at all to the people who are in training today, where night call is really a very important part of training and of junior and senior faculty responsibilities. Very different.
Interesting. Okay, interesting. Um, and just going back again, you said your daughters are within 5 years, so late 50s through early 60s, right? What we're talking about here. Um, are there other things you'd like to say about your early years at Grady, um, being again the founding director of the cardiac clinic? clinics rather in 1960, and then I know you served as I saw from your CV you served as director there until 2020, um, uh, and we've been focusing on the early years, your early years at Grady and in the Atlanta medical community. Is there anything else you want to say about that time?
Well, just that it was very exciting because new problems appeared as new management and new therapies appeared, and there was the opportunity to address them so that things never got boring. And there was the opportunity, just as medical care grew, to have the care system grow. And I don't think a month went by when something new had not come onto the scene that we had the challenge to decide how we were going to use it, what we were going to do, how we were going to work it into our system of care, and how we were going to do the teaching and training that is really a very important part of the academic mission.
Great. Um, I see we have about 15 minutes left today, and
Okay.
we'll do another session. So I think what I want to turn to now for our last 15 minutes a bit is your research beginnings, because I know you began contributing to research very early in your career. And I read that you have authored or co-authored over 1,700 scientific and review articles and book chapters, which is a number that is mind-boggling. Um, what were your first research interests?
Well, the first major research was the cardiac rehabilitation.
Mhm.
And that was a federal grant that continued for a number of years and that really provided funding that allowed us to do the things that we wanted to do and to establish this as a part of cardiac care. So that was one of the things. Then we did one thing that was really fun, and I ended up getting a grant for stadium coronary care. The Turner Field, the original Atlanta baseball stadium, is just a stone's throw from Grady Hospital. And people were beginning cardiopulmonary resuscitation as emergency care. And I was involved very much with the Georgia Heart Association at the time. I think I was an officer already. And we got the idea of saying here was a new stadium being built, and the stadium had ramps all around it. And could we get something where we could have an emergency care system? And we set up in the first aid station an emergency care system and equipped a golf cart with a stretcher that could go around the stadium. And over the weekend, the Heart Association trained all the stadium employees in CPR. And of course, it made the front pages of the newspaper because on Saturday there was not much news, and people were very excited about it. The Heart Association was excited, the hospital was excited, the stadium was excited. And within the first few weeks of the stadium opening, there was a cardiac arrest. And it occurred not in the stadium, but outside the ticket taker's office. But the ticket taker had been trained in CPR and provided CPR until the emergency medical arrived, and the patient survived and was taken to Grady Hospital. And a film was made about it that was shown on local television, et cetera. So it was just sort of a venture. And obviously, the stadium subsequently took this over in terms of emergency care. But for a number of years, our trainees were doing both rotations at the ballpark and at Georgia Tech for football. So we were providing emergency care and they got free tickets. And the fellows loved being participants in the research. And we had a number of impressive saves over that time.
Really interesting. Um, how did you learn how to ask research questions and design studies? I mean, now obviously it's been decades, but how did you first learn how to do that?
Well, it was an answer that I wanted. Very simply, it was an answer that I wanted, and I said, "Is there a way to get that answer?" And that's the basis for designing a study. And uh, subsequently, because of my interest in research, I was involved in a lot of the multi-center studies that cardiology had. And I was fortunate early on to be involved in one of the early preventive studies, the Coronary Drug Project, which was a study just of men. And I was co-PI for the Grady site, and therefore got to go to the meetings. And the prestigious investigators who led this put me on the publications committee. I don't know whether it was because they thought I could make coffee or because they thought I would take minutes, and I do neither of them. But nonetheless, I was exposed to some of the people who did some of the most important writing to the medical community. Because what Coronary Drug Project showed was that most of the therapies that were currently being used to treat coronary disease in men either were dangerous or were not beneficial. And the question is, how do you take this message to the community that what they've been doing for all these many years is bad and has to be changed? And some of the senior people who had enormous writing skills, I had the privilege of working with them and learned how to write. And that has helped me subsequently. Uh, I was one of the associate editors for the first 15 issues of the textbook, The Heart, again, because I could write, I could read, I could proof, etc. And I find that writing comes very easily. And I've been able to mentor people in writing, and now almost any time I'm asked to do a monograph or what have you, I will get a junior faculty member or sometimes even a senior trainee to either be first author or co-author with me, because it gives them experience. It gives me the opportunity to teach them how to write. And I think I've taught a number of people who've gone on to fairly prestigious positions and done writing of their own.
Amazing. I've certainly, in preparation for this interview, saw videos with a number of people who were clearly so grateful to you for that kind of thing. Sounds like you've been an incredible mentor. Uh, what about, um, and we can start this now and continue it in the next, uh, our next interview session. But I think about, various themes that would later define your work. You've mentioned cardiac rehab, also, of course, women's heart health, um, uh, cardiac care and aging. Looking back, what do you think were the earliest seeds of those themes, like women's heart health, for example?
Well, I was seeing patients in the clinic and seeing women who were in the hospital with heart disease.
Mhm.
And I had been trained and taught that heart disease was a man's problem. Obviously, rheumatic disease and mitral stenosis was recognized as a problem for women. But coronary disease, the major killer, was considered a man's disease. And yet I was seeing women with heart attack in the hospital and seeing women who had chest pain in the clinic. And going to the literature, there was absolutely nothing that could help me discern what to do. And all of the studies involved men. And with my usual persistence, I went to the Heart Association, who told me it was not relevant, and to the American College of Cardiology, who told me it was not important. and to the National Heart, Lung, and Blood Institute with the same response. But I continue to say they're all women living with heart disease, and we have to get information about how they present, how to diagnose them, how to treat them, etc. And finally, after a number of years, the people at the National Heart, Lung, and Blood Institute, I think it may have been the National Heart Institute at the time, I'm not sure blood and lung had been added yet, they decided to hold a workshop. And it was my privilege to chair that with Leon Spiroff and Barbara Packard. And we defined what was known and the knowledge gaps. And the knowledge gaps were really the most important. But the time from a workshop to a conference is usually about 2 years. This one was 6 years. But when we finally had that conference, again, it was my privilege to chair it with Dr. Spiroff and Packard. And the manuscript that came out from that conference was the basis for the New England Journal of Medicine article. And at that time, the New England Journal of Medicine editors told me that in their experience, it was the first time that coronary disease and women had appeared in the title of an article in a major journal. And I think that this started the questioning, and people looked at the knowledge gaps and realized that the knowledge gaps applied to the patients they were caring for. And I think this is what started the interest. And obviously it has grown and grown. And someone showed me a quote from Emerson. I don't think it was my inspiration, but I think this is what's happened. Emerson said, "Do not take the path well traveled. Go rather where there is no path and leave a trail." And I think this is what has happened. And over time, this trail has turned into a major information highway just because other people have looked at the questions and began to seek answers. That to me, I think, is probably the most exciting thing that I've seen. And everyone has a leadership style. And I think mine is different from most people. Most people lead from top down, and I tend to lead from bottom up, meaning that what I like to do is to get people enrolled in my vision. And once they're enrolled in my vision, to say, take off and go in the directions that interest you. And I think this is what's happened with women's heart health and women and heart disease. And it has been so gratifying to see. There are now books on women and heart disease.
I think this is a perfect place to end our session today. I cannot thank you enough, Dr. Wenger. In our next session, we will continue to talk about some of the major contributions you have made in women's heart health. We'll start back with that again, because I feel like we've just started there, as well as cardiac rehabilitation and geriatric cardiology and leadership, right? You were just talking about the fact that you have a different leadership style than many people. And we'll also talk more about your personal life and legacy. Is there anything you'd like to add before we pause for today?
No, I think this is a very good stopping point. And you really ask very much the right questions that give us a continuous story, and I appreciate that.
Oh, well, thank you very much. I can't tell you what an honor it is to be talking with you today. And I look forward to continuing this in a couple of weeks.
Okay, very good. Have a great holiday. Bye.
You too. Thank you. Bye-bye.